few general principles that apply when you read, a joint X-ray. So when you order X-ray, joint X-ray, what you're expecting to see in the X-ray. So you're expecting to see bone, soft tissue, and the joint. And the joint is represented by, the joint space here. This is the joint. And actually, this space is not empty. You know what's there in that space? Cartilage. Okay, so there is cartilage there. So this represents cartilage. Okay, so when you order joint X-ray, you expect you can see the bone, any changes in the bone, any changes in the soft tissue, or any changes inside the joint. And these changes inside the joints, usually you can see, if there is any problem with the cartilage, because you can see it here in the joint space, or if you can see if there are any erosions, for example, or any extra bone formation. All these information you can get from X-ray. So the second general principle is that, like any X-ray, for example, if you order a chest X-ray, there is a system, right? So when you read a chest X-ray, you need to go through a system so that you don't miss anything on the chest X-ray. Same applies to the joint X-ray. So the system we use to read a joint X-ray is called the ABCD's approach, so that we don't miss anything. Even if you're not an expert in the joint X-ray, if you follow this approach, you're unlikely to miss anything, significant on the X-ray. And what we mean by ABCDs, so A is alignment. So first thing, we see the alignment of the joint. Next, B is bone, so we check the bone. And C, any thought? What is C? C is cartilage. Okay, so that's the cartilage. I told you it's inside the joint space. So these spaces are filled with cartilage. And D is the distribution of the abnormality seen on X-ray. So some diseases, they tend to have a predilection for certain areas. For example, osteoarthritis loves the IV joints, and also psoriatic arthritis, while rheumatoid arthritis spares the IV joints. So some diseases, they like certain locations. So sometimes distribution of the lesion can, give you a hint to the diagnosis. And then S is the soft tissue. All right. So this is the ABCD's approach when you read any joint X-ray. Another general principle is that you look at all views available. For example, if you see this patient is coming with trauma to his foot, and he's coming with pain and swelling, so the doctor suspected fracture because of the trauma. But when they did the AP view, really there wasn't any abnormality to be appreciated in this view. But then same patient on the lateral view, you can see the fracture here. Okay, and this is the same patient. And so sometimes you need two views to visualize the abnormality, because bone is is a 3D structure. So the lesion could be not in line with the beam of the X-ray. So maybe you need to visualize it from another angle to be able to see it. So especially if you're thinking fracture, it's better to order two views so that you don't miss the fracture. Right? Okay, and this is another patient here who he was drunk and he punched the wall with the fist, and then he came with pain and swelling in the wrist. So because of the trauma, he won't rule out a fracture. So this is his AP view X-ray, which looks unremarkable, and he has pain here. But this is the lateral, and you can see here, I don't know if it's obvious, there is like a hairline, like you can see it. Yeah, do you see the black line? This is the fracture. This line here, the black one. Oh, sorry, the pointer doesn't show there. Okay. See, there is a pointer. I don't know, you can call the technician. Yeah, I need that. you know where the arrow is pointing, you know, there is like a thin black line, so this is a fracture, which was obvious only on the lateral plane, it wasn't obvious on the AB. Okay. Another general principle is in some joints it's very helpful to compare with the other side. So they have problem on one side, you better do X-ray on both sides. In some joints, like for example the hip joint, for example, because sometimes your eye will not appreciate the abnormality unless you can see the normal side and the abnormal side. For example, in this patient, he has hip pain here. So I don't know if you can see anything abnormal with this X-ray. Okay. While if this is his other side, the normal side, now you can appreciate the problem more. So you see here the neck of the femur here is really nicely outlined, and it's long and sharp. While you see here it's collapsed, and there is this line here, which is a fracture. So he has a femoral neck fracture. So sometimes comparing to the other side can help. And if you have old images of the same joint, it's helpful to compare with old images, because, for example, this patient with fracture of the femur, and when they compared to his previous images, they saw there is a little lesion. Can we dim the light? Because this is X-ray, we need to be dark. So you see there is a little lesion here, so he had a bone metastasis, and then he got fractured there. Okay, now I cannot see the laptop. No, it's fine. Okay, another thing that you need to do for very important, when you have patients with osteoarthritis of the knee, which is very common, and you want to image the knee for osteoarthritis. So it's very important you order a weight-bearing image. Okay, it has to be weight-bearing. Not supine. So you don't image the patient when they're lying down, because the knee is a weight-bearing joint. And if there is any space joint reduction, it may not show if the patient is not putting weight on the knee. For example, in this case, this is the same patient, but this is when he's lying down supine, and this is when he's standing and weight-bearing. So you see now the joint space narrowing is evident when he put weight on his knee, while when he was lying down, the joint space was looking normal. Okay, so if you want to do X-ray for a knee osteoarthritis, always make sure it's a weight-bearing X-ray. And the other thing, you need a lateral view again, because there is a compartment of the knee joint which you cannot assist on the AV fold. So on the AV fold, you can assist two compartments, the medial and lateral compartments, but the patellar compartment only evident on the lateral fold. So you see there is no joint space here between the femur and the patella, right? So there's loss of, so there is patellofemoral osteoarthritis. So sometimes patients will have no normal joint space here, but they will have all the abnormality is in the patellofemoral compartment. So if you don't do the lateral, you're going to miss this. And patellofemoral OA is the most common symptom of this is, when they pray, they have pain when they bend their knees. So they said we cannot pray, we have to pray, on a chair, we cannot bend. So this is usually a patellofemoral osteoarthritis. Right, so first thing, so we come now to the ABCDs approach. So you order a joint X-ray, now you want to read it. So first thing we look at A is alignment. So alignment is referred to the way the axes of the bones line up, in relation to each other. So the adjacent bones, and you see the long axis of the bones that are adjacent to the other, if they're aligned or not aligned. You should be able to trace, the axis of the bones smoothly, right? So it's like a one line. But you see here, when there is joint dislocation, the long axis of this bone is not in line with the axis of this bone. So here there is malalignment. Okay? So the first thing we look at is alignment. So here are a few examples of malalignment. So you see here there is a dislocation. So really the long axis of this bone really doesn't align with this long axis of that bone. Again, with displaced fracture, there is malalignment, and here there is ulnar deviation, so this axis does not line up with this axis. Right, okay. Next one is the B, obviously, so we need to look at the bone. So the bone, the first thing, we look at the outline of the bone, and then we look at the bone itself. So the outline of the bone, we need to know two things, or to check two things. First of all, we need to check the continuity of this line. So this line should be continuous. When you trace it with your eye, it should be continuous, like this one here. You trace it like this with your eye, and it's continuous. But when you trace this one here, there is a break in the line, right? It's not continuous, right? So there is a fracture here. So first thing, you check the continuity of the outer line of the bone, which is the cortex. And second thing, you check the sharpness. So it should be like this one, it should be continuous and sharp. Okay? This one is continuous, but is it sharp? No. This is not sharp, right? This is fluffy like cotton, right? So this is not sharp. This is what we call a periosteal reaction. So there is a problem here in the cortex which we call periosteal reaction, and we'll come to it later. So continuity and sharpness. The outline of the bone, see if it's continuous, if you can trace it with your eye without any interruption, and then you see if this line is sharp or not sharp. Right, so this is called periosteal reaction. And periosteal reaction, actually what is periosteal reaction? So the periosteum of the bone, when it's irritated for any reason, for example, infection, trauma, inflammation, post-operative, and any sort of stress in that area, is going to irritate the periosteum of the bone. And when the periosteum of the bone is irritated, it produces bone. So there is new bone formed on top of the bone that's already there. Right? So if we go back to this one, sorry. So you see here, this is the actual cortex down, and this is all new bone that formed above the cortex. Okay, so this is a new bone that been formed in relation to stress that's irritating the periosteum. Okay, so periosteal reaction really doesn't give you any diagnosis. It just tells you that there is some process going on there, and it's irritating the periosteum. But when you look at the periosteal reaction, if it looks solid, so this one is solid. If it looks solid, usually it's the underlying cause is benign. It's like, for example, an inflammatory arthritis, a benign tumor, or trauma. But if it's anything but solid, if it's like this, laminated, if it's speculated, then this is not a benign. This could be a malignant tumor or infection, for example. Right? So you see, this is solid, periosteal reaction. So there's an underlying benign process, and in this case, it's osteoma. Really, you don't need to know osteoma. Even I don't know, but I'm just telling you that if it looks solid, it means the underlying problem is benign. But you see this one here, there is a black line between, like this one, you can't see anything black inside, right? So it's bone on bone. But this is bone, and then there is a black line here. So this is the laminated type, the one which is like this, layers. Okay? So this is laminated. So this is there is an underlying pathology which is not benign. Right, and this is another example of the periosteal reaction. Again, this is not a benign because it's not solid. And this is a Ewing sarcoma. Right. Now we finished looking at the outline of the bone. So I know you need to look if it's continuous and if it's sharp. Okay. Now, after we look at the outline, we look at the bone itself. And what we need to see in the bone, first of all, is there is any bone missing. So is there is any bone loss. And the example of bone loss, erosion. So erosion equals bone loss. For example, this joint here is completely, you can't see the joint. It's completely disappeared. It's destroyed because of septic arthritis that was not treated. So there is a joint damage, so you can't really see the joint. So there is bone loss here. This is a big erosion in patient with gout, and you can see the tophus here, the big tophus. Okay. And the thing about gouty erosions is that they can happen outside the joint. So this is the joint, And the erosion is outside the joint because of the tophus, while all the other inflammatory arthritis, the erosions are inside the joint because this is where the pathology is. With rheumatoid and psoriatic, the problem is inside the joint, but with gout, it can extend outside because the tophus really can reach anywhere. So if it reaches the bone outside, it will erode the bone outside. Right. Other examples of erosion, so you have here, this is the gout. And any idea what is this? This is an erosion here. Any idea what is this? Is a figure. This is psoriatic, this one. The pencil and cup is psoriatic arthritis. What we call the pencil and cup. So the proximal bone is eroded like a pencil, and the distal bone has got a new bone on the side like a saucer. So it's like a pencil and a cup. This is typical of psoriatic arthritis. While this is, we call it seagull sign. See, like a seagull? This is the seagull. Like, when we were kids and they ask us to draw, the beach and, so what do? You draw the beach and then on the sky you will do like this, right? Like these are the birds in the sky, right? The children, they draw birds this way. So this is called the seagull sign. Seagull sign is typical of erosive osteoarthritis of the hand. Okay? So you get an erosion in this, in the proximal bone, there is an erosion, and the distal bone, there is an osteophyte. So erosion and osteoarthritis looks like a seagull. So this is an osteoarthritis. And of course there are other signs of osteoarthritis. So these are osteophytes on the side. There are extra bones, the osteophytes. And there is subchondral sclerosis. Sclerosis on X-ray means it's more white than normal. Sclerosis means there is more bone than normal, so it makes it more white. And it's called subchondral sclerosis. It happens in osteoarthritis because there's a process of the body trying to repair the damage. So when they try to repair the damage, they synthesize more bone. But sadly, really, it doesn't help the problem. It just accumulates there, and it gives you this sign on X-ray, subchondral sclerosis. So these are all signs of osteoarthritis: subchondral sclerosis, osteophytes, central erosions. Again, so we're still seeing examples of bone loss, which are the erosions. So this one, anybody? So this is again psoriatic arthritis, pencil and cup. So you can see here how the bones are eroded like a pencil shape. You see, this is like a pencil shape, right? And this is like an extra bone on the side, so it becomes wider like a cup. And there's like a cup on top of a pencil. So this pencil, cup, and psoriatic arthritis. This again bone loss. So this is in rheumatoid arthritis. You see the marginal erosions here in rheumatoid, and this is a gouty erosion. So these are all examples of bone loss. Now the other thing we need to see in a bone, okay, we can look for any bone that is lost, but we can also see if there is extra bone, so new bone formation. A new bone, again, this is, can anyone, again, yes, so this is the seagull, right? You can see the seagull? Seagull, okay? So this is primary osteoarthritis of the hand, nodal osteoarthritis, so you get the subchondral sclerosis, okay? And you get the osteophytes, so you see the extra bone coming from the sides, see? These are all extra bone. Clinically, these extra bone will be seen as Heberden and Bouchard nodes of osteoarthritis. So I see nodes on the sides of both sides of the joint, like small little lumps on the side. It's called Heberdens and Bouchards because of the osteophytes. So these are examples of new bone formation. Because as I told you, in osteoarthritis, the bone will try to repair the damage by making more bone. Again, a new bone formation. So this is an enthesitis of the plantar fascia, so inflammation of the site where the plantar fascia attaches to the bone. The site of attachment, because of the inflammation, you get extra bone formation here, enthesitis. And again, this is, you see the outline here is not sharp, right? So it's flat, it's not supposed to be sharp, but here it is not sharp, right? Is it obvious? You see? So this is again very osteo reaction in patient with psoriatic arthritis. So this is an example of extra bone. And this is ankylosis. So this is, again, can you when the joint, the cartilage is completely destroyed, there is no joint space at all, and there will be bridging, bony bridging between the two bones. So this is again bony bridging. This is another example of new bone formation. Right. Now we looked at the bone, we see if there is missing bone or there is extra bone. Next we need to see the texture of the bone. So you see this is the normal texture of the femur. It's like very thin hair lines. This is the normal trabecular pattern of the femur. So this is the texture of it. So if you look here, can you appreciate any problem in the texture? So if you take, for example, this the ilium here and this, or even here and here, can you appreciate the difference in the texture of the bone? Right. So here you have a fine trabecular matter, but here you have a coarse, irregular pattern. Right? Coarse and dense, irregular pattern. So this is abnormal texture of the bone and the invasion of Paget's. And a more advanced case of Paget's will be even more obvious. But this is an example of abnormal texture. So this is a normal texture, and this is abnormal texture. Again, the texture of the bone here is grossly abnormal because of TB and osteomyelitis in this child. Again, just talking about texture, so you can see, so this is a normal texture, or this is a grossly abnormal texture. And in different cases, you really don't need to know the diagnosis. You just need to know the concept that the texture is abnormal. Then you can seek help from the radiologist. So you see, I have an X-ray with abnormal texture. I need your opinion on what could this be. Okay? Really, you don't need to know that this is what's the underlying diagnosis, because we are not radiologists. Okay? Right. The other thing we need to see in the bone itself is mineralization. So mineralization could be either normal or could be reduced. So like osteopenia, either normal or osteopenia. And the osteopenia can be either only limited around the joint, which we call it periarticular osteopenia. So you see the bone here looks normal, but it's osteopenic only around the joint. Or it can be generalized. Oh, sorry, this is all periarticular osteopenia. Or it can be diffuse or generalized. The diffuse one, how can you know if it's diffuse? If we're looking at the hand, you take the first two fingers and you take the cortex. Okay, the width of the cortex on both sides, if you add them, if you look now at this one with the osteoporosis, if you add the width of the cortex on both sides, it does not add up to half the distance, right? It's small. It does not add up to half this total distance. So this is diffuse osteopenia in this patient. Right. So when you look at the bone, first of all, look at the outline of the bone, see if it's continuous and sharp. Next, you look at the bone itself, see if there is any bone loss, if there is any extra bone or new bone formation. Look at the texture of the bone and look at the mineralization of the bone. And again, you don't have to know how to diagnose any diseases. You just to know how to pick up if there is something abnormal, and then you can discuss it with your radiologist. Right. Now, we come to the C now, so we finish alignment, we finish bone, we come to C, which is cartilage. So cartilage is the space between the bones. It's the joint space, which is filled by cartilage. It's not an empty space. So the cartilage could be either normal, reduced, or increased. Okay? Increase is not very common. Actually, it happens in only one condition, that increase the joint space. But decreased joint space is common, and it's most commonly seen with osteoarthritis. Okay? So this is osteoarthritis, and you can see non-uniform joint space reduction. So it's more on one side than the other side. And this is primary osteoarthritis. And again, you can see the extra one, right? You see these are the osteophytes. And you can see the subchondral sclerosis. These are all signs of osteoarthritis. And the non-uniform reduction in joint space happens in primary osteoarthritis, while in secondary osteoarthritis, usually it's uniform reduction in joint space. So this is usually secondary to another joint problem, for example, rheumatoid. But this one is primary. And again, this is an osteoarthritis here. Again, you can see the osteophytes, chondral sclerosis, and asymmetric joint space reduction, and you can see the seagull. Right. Again, now this condition, this is increased joint space, right? So what condition can give you increased joint space? So again, this is the same. This is another patient with the same condition, but this is in the foot, this is in the hand. So these are very wide joint spaces, right? This is very wide. This is acromegaly. Okay, so as acromegaly can cause enlargement in many organs in the body, it can do the same with the cartilage. It can increase the size of the cartilage, so you can have increased joint space. Now we come to distribution. So as I told you, some diseases, they have certain distribution of abnormalities and can give you clue to the underlying process. So if you have distal interphalangeal joint involvement, DIP involvement in the hand, usually it's very common in, so what is this again? Anyone see? So you can see here the seagull, subchondral sclerosis, and the osteophytes. Okay, so this is osteoarthritis, primary osteoarthritis. Okay, so DIP involvement is very common in osteoarthritis and psoriatic arthritis. It never happens in rheumatoid. Actually spares the DIP. Rheumatoid doesn't like DIP joints; it hates the DIP. So if you see problem in DIP joint, it's not rheumatoid. Okay. Again, this is another classical joint that's affected by osteoarthritis, the CMC1 joint, or we call it the basal thumb joint, osteoarthritis. This is very typical of osteoarthritis, joint involved osteoarthritis. And then you have here osteoarthritis in MCP2 and 3. So you see there is the joint space reduction, so that's osteoarthritis, and you see here the osteophyte, the big osteophyte like a hook. Okay. This is osteoarthritis secondly to hemochromatosis. So hemochromatosis, they love these two joints, they have predilection for these two joints, and hemochromatosis usually causes hook-like osteophytes. So I'm just giving you an example of how distribution of the lesion can give you a clue to some diseases. Of course, not all diseases, some of them. Now we come to S, soft tissue. So what can we see on X-ray in soft tissue? What abnormalities can we see on X-ray? So first of all, we can see lumpy soft tissue swelling, so like lumps. So if you see here, again, so these are all cases of gout. Okay, these are autophagy, this is rheumatoid nodule, but I'm showing these are all gout. Okay? So can you see here the soft tissue swelling? This is all soft tissue. And these are all tophi. But why this tophi is more white than this one, and this one is more white than that one? This is almost like soft tissue density. It's not very dense. This is denser, and this is denser. So what makes the tophus appear more white on the X-ray? Sorry?
Calcified.
Sorry. Okay. It's the calcium content. So when the tophus gets calcified, the more calcium in the tophus, the more white it appears on the X-ray. And this is a rheumatoid nodule. So rheumatoid nodule doesn't have any calcium in it, and it appears almost like the surroundings of tissue. Another examples of calcification. So this is in systemic sclerosis patient. They're very known to have calcinosis. I don't know if you heard about the Crest disease, and part of the Crest disease is the calcinosis. So it's calcification in the subcutaneous tissue. Can happen anywhere, but more common in the fingers. Again, in pseudogout, the old name is pseudogout, the new name is called calcium pyrophosphate deposition disease, CPPD. We don't call it pseudogout anymore. So in CPPD, you can see calcification inside the cartilage of the knee, which is called the chondrocalcinosis. And again, you can see the chondrocalcinosis in the triangular fibrocartilage of the wrist. So these are all examples of soft tissue abnormalities can be seen on X-ray. Again, more calcification. So if you see a calcification, that's like tubular structure or longitudinal structure right here. Right. So this is usually following something. It's what is following? What is there near the joint that's elongated? It's tendon. Okay. 10 minutes. So usually classification of 10 minutes. And this is a hydroxyapatite deposition disease, another crystal arthritis. Besides gout and pseudogout, or there is also the hydroxyapatite deposition disease. It is usually more common in young females. Another sign we can see is soft tissue swelling, for example. So this is a patient. This finger is normal, but this finger is grossly swollen, right? It's very obvious. And the swelling is all involved the whole digit. So this is what we call the sausage digit. This is dactylitis. Okay? So this is dactylitis, which is visible on the X-ray. While you see this patient has synovitis in this joint, and the swelling is localized around the joint. So it's more like fusiform. It's not like dactylitis. It's not like sausage shape. So this is synovitis around the joint causing this localized swelling. This is dactylitis. And this swelling here is caused by an osteoarthritis by the osteoclide, the extra bone. Okay, so these are all examples of soft tissue swelling that can be seen on X-rays. Okay. Now another thing in soft tissue is something we call loose bodies. So loose bodies are they happen in patients with osteoarthritis, usually of the knee. So these are like, fragments of the bone or fragments of the cartilage. They get detached from the joint. So they get detached, if it's cartilage, it gets detached from the cartilage or it gets detached from the bone. And then it moves freely inside the joint. It's like swimming inside the joint. These small fragments, they move inside the joint. And if they get stuck inside, they can cause mechanical block of the joint. So a patient will be walking, suddenly his knee will lock. So it will stop moving and it will be very painful. This is called knee lock. And this is usually because of loose body, presence of loose bodies. And actually presence of loose body that causes frequent mechanical blocking is the only indication for knee arthroscopy. So they do arthroscopy and they remove all the loose bodies from inside the joint. Okay, now, so any question about reading the X-ray? So ABCD approach, alignment, then B, the bone, you look at the outline, it's continuous, it's sharp, and then you look at the bone itself. Any bone is missing, any extra bone is there. You look at the mineralization, you look at the texture of the bone. And then you look at the joint space, which is the cartilage, if it's normal, reduced, or increased. As I said, increased not common, it only happens in acromegaly. And then you look at the distribution of the regions and if there is any soft tissue abnormalities. Right? So, for example, if we take this case, you see the alignment. Alignment is maintained, maybe a little bit here, but nothing really major. Okay? And then if we look at the bone, so you trace the bone. You see if it's continuous, if it's sharp, that's fine. You survey all the bones with your eyes, so it's all sharp and continuous, right? But if you look at the bone here, if you look at the cartilage here, so what happened with the cartilage? It's lost. There is no cartilage, right? There's joint space reduction. And yeah, seagull, maybe you can see it more here, maybe because this is a little bit advanced. Seagull, you can see it more, and the erosion is visible, and the osteoclide that coming from the top is visible. But because this is advanced and there is almost bridging, maybe you cannot appreciate it too much. But there is loss of joint space in the DIB joints. So as I told you, osteoarthritis has predilection for DIB joints, also in the DIB joints. And which other joint also has problem? Base of the thumb. These are all classic sites for osteoarthritis. So this patient has osteoarthritis of the hand. Okay, now this one with the knee. Of course, it's limited view, so you cannot comment on the alignment. But if we look at the striking thing here is the texture of the bone, right? This is what's striking with the first look. The texture of the bone is abnormal. You see like big cysts, right? Like big cystic lesions here. Okay. And also there is joint space loss, right? Which is uniform. So this patient has a secondary osteoarthritis, and he has large cystic lesions in the femur and the tibia. Okay. So this is actually this is a case of rheumatoid arthritis with what you call them geodes. So patients with rheumatoid, they can form like big cystic lesion in the bone. We call them geodes. Right. Okay, this one is easy. So anyone can give me diagnosis? So there is asymmetrical joint space narrowing. This is subcondylar sclerosis, the white line here. So see, this is the whiteness is normal, the whiteness is increased. This is subcondylar sclerosis, joint space reduction, extra bone osteophytes on this side. So this is osteoarthritis. Okay, this is a primary osteoarthritis on the knee. Okay, this one is easy, so you can spot it from this. This is what? This is like pencil, right? This is like pencil, right? But this is psoriatic arthritis in here. Pencil-like cup. Again, this is osteoarthritis. So see BIP and BIP joints. Joint space loss, subcondylar sclerosis, osteophytes, so this is osteoarthritis. And you have also changes in the vasopharynx, subcondylar sclerosis and some joint space irregularities. Right? Again, this is... Okay. This is a secondary osteoarthritis. Why? Because you see the joint space narrowing is uniform. When the joint space narrowing is uniform, it's usually secondary to another disease. So the cartilage is damaged because of something else, not primary osteoarthritis. And do we have a clue to what could this something else be? So you can see here, although it's faint, there is like chondrocalcinosis. If this was a proper PACS to view X-rays, and you can change the contrast of the image, maybe you can make it more clear. Like, whitish, a faint whitish light here, which is chondrocalcinosis. So this is osteoarthritis secondary to pseudogout, or what we call now crystal pyrophosphate deposition disease, CPPD. Okay, so this image, what's striking here again is what abnormal texture. The texture is abnormal here. So you have like a dense, a very dense kind of lesion here on this side of the femur, and this is osteonecrosis of the knee. Okay, so you have abnormal texture of the bone. This is an example of abnormal texture. Right? You see here, this is the normal texture, this is an abnormal texture. And if you don't know what is this, you can again tell your radiologist, I have an X-ray of the knee that has an abnormal texture, I want to discuss it with you, what could this be? As long as you know that there is a problem in the texture, you don't really need to be expert in finding the diagnosis, because there is someone more specialized to tell you, which is the radiologist. And this joint here, you can see that really there is no head or tail of this. Everything is messed up, right? So everything is destroyed, everything is damaged. It looks bizarre, it looks peculiar. So this is the Charcot's joint, or neuropathic joints. It usually looks like this. This Charcot's joint. Yeah, I think that's it. So yeah, I'm happy to take any questions. So. No questions? Okay, I think that's it. You can join other sessions now if you wish, other workshops, because we're going to repeat the workshop this one again now. It's going to go for